afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interest. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Amaka Ofuani. Dr. Ofuani is a third-year internal medicine resident here at Northeast Georgia Health System. She attended Burrell College of Osteopathic Medicine at New Mexico State University for medical school. She recently accepted an offer to practice as a hospitalist back in her hometown of Tallahassee, Florida, and hopes to give back to her community what has been given to her. Join me in welcoming Dr. Ofuani.
Hey everyone, thanks for joining me for my presentation today. It's called HDL is Higher Better. I have no disclosures, and these are my objectives that we will tackle one by one. My outline. All right, so if you guys take a look at this text message between myself and my peers, this is actually the inspiration for why I chose this topic. So I had some labs done basically a few months ago, and I saw my HDL, and as you can see, it was 82, and I was extremely proud. So I texted the group, as you can see, just did some labs for the smoothie study, and guys, my HDL is what's got me in a good mood. I might have some fried chicken later. So based on this presentation, hopefully you guys can let me know if I should have that fried chicken or not. So let's see. All right, so a little bit about HDL pathophysiology. As you guys know, our cholesterol that we intake through our diet gets reabsorbed through our intestines and packaged into chylomicrons, makes its way over to the liver, in which dietary cholesterol combines with endogenous cholesterol and triglycerides and are packaged into VLDLs. VLDL then travels through our circulation to other organs, and triglycerides are extracted from them, creating LDL, and that's muscle and adipose tissue that extracts those triglycerides. So from that LDL, peripheral cells uptake LDL, and then some of that excessive LDL gets deposited into our blood vessels. And this is where HDL comes into play. It's kind of like a dump truck. Transports that excess cholesterol from LDL from the peripheral cells and the walls of the arteries back to the liver in a process called reverse cholesterol transport. And from there, you know, the cholesterol can be excreted into the bile or just excreted in our feces. So these cholesterol deposits are a major feature of atherosclerosis, and removing cholesterol from the arteries is thought to be an important process or component in the prevention of cardiovascular disease. So why do we care about cardiovascular disease? Well, it's because it's the major cause of death, in particular in the United States and globally. Heart disease is the leading cause of death in the US for the past 100 years. So that's pretty significant impact. Interestingly enough, heart disease, along with stroke, actually claimed more lives in 2021 in the US than all forms of cancer and chronic lower respiratory diseases combined. So globally, about 18 million people die each year from cardiovascular disease alone. So some data that we have that gets published every year in January comes from the American Heart Association in conjunction with the CDC, as well as NIH and other government agencies. And it's basically an up-to-date statistics on heart disease, stroke, and other vascular diseases. And from that information, we found out that since 1950, actually the death rates from cardiovascular disease have declined drastically by 60%, and we'll talk about some of the reasons why. But lately, in the past few years, the rates have slowly crept up, and just in 2023, because this is information from the 2024 one, there were over 900,000 deaths. And in terms of the burden on our healthcare system of costs, that's about $422 billion in direct and indirect cost. Indirect costs include productivity and mortality. So let's see here. All right, so we really can't talk about cardiovascular disease without talking about the Framingham Heart Study. This is a study that is the first long-term cohort that followed cardiovascular development over a long period of time in 3 different generations. And this study began in 1948 and really helped us gain more information about the natural history of cardiovascular disease. These patients that were in this study underwent physical examinations, gave blood test samples, lifestyle information, medical history at regular intervals. So as you see here, it's a 1948 study. The original cohort was about 5,000 people that lived in Framingham, Massachusetts, who didn't have cardiovascular disease symptoms. There were various cohorts that were added later. The offspring cohort included what it says, offspring of the original cohort. That was in 1971. In 1994, they added the Omni cohort, the first one to reflect the increasing diversity of the community. So they added more African Americans, Hispanics, Asians, Indians, Pacific Islanders, and Native Americans. The 3rd generation cohort, this is where the offspring participants were asked to update information about their children. And then you have the new offspring cohort that was added in 2003. If the spouse of an offspring was never enrolled, they were enrolled then. And then lastly, you have the 2nd generation Omni cohort, which is an expansion of the first Omni, so including more diversity. But really the Framingham Heart Study led to the identification of major cardiovascular risk factors and has formed kind of the frame for what we tell our patients are their risk factors for developing cardiovascular disease. And as you see here, I want to focus more so on the elevated cholesterol aspects. This is just an infographic kind of summarizing what I said. The interesting thing here is that it's still ongoing. So it's been over 70 years and we're still pulling data from this. And there's been over 3,000 spin-off studies that were published based on the information from the Framingham Heart Study. This is just one spin-off of information that we gained looking at the cholesterol findings. So this is just information based from 1987 to 1991. The participants were divided into 8 groups. As you can see, the main groups were low HDL and high HDL. And to the side here, you can see what we mean by low and high. So for the low HDL group, the risk of cardiovascular disease was significantly greater when the triglycerides were also elevated. You'll see that's 30% higher risk. Also was high in the low HDL level when LDL was elevated as well, another 30% risk. Now, looking at and of course, it's extremely elevated when both the triglycerides and LDL are elevated. Looking at the high HDL group, so, as you see here, anything greater than 40 for men, greater than 50 for women, you see that you have a significantly decreased risk of cardiovascular events, particularly when both the triglycerides and LDL were optimal. Also, patients with high HDL had elevated triglycerides and LDL didn't really see much benefit. It was not statistically significant with a 10% reduction. But just from this data right here, this plain simple data, this is kind of where we got this idea of good and bad cholesterol. And also where we got the commonly used statistic that for every 1 milligram per deciliter increase in HDL, cardiovascular disease risk decreases by 2 to 3%. But we'll see if this is actually true. But as I said, from this study, this is where we were thinking, okay, maybe we should try things that increase HDL. So from there, let's move on to methods to raise HDL that were investigated in the literature. First, I'll start with the pharmacological agents. As we all know, niacin was something that was thought to help because it does raise HDL and it lowers LDL. This is a trial called the AIM-HIGH trial that was started in 2011. As you can see, there were over 3,000 participants, and it was a 3-year follow-up. And the trial basically was investigating whether simvastatin versus placebo plus simvastatin with extended-release niacin would be beneficial in terms of decreasing cardiovascular events. And really, there was no significant difference when niacin was used in major cardiovascular events, despite the fact that it did increase HDL by 25%, actually, compared to the placebo, or compared to patients just on simvastatin alone. And actually, the study was stopped early because of the lack of efficacy, and there was a slight increase in the incidence of patients who suffered from ischemic stroke. This is just a little picture of a common side effect from niacin as well, known as the niacin flush, because it does increase prostaglandins. But overall, this study really made physicians and clinicians re-examine the role of niacin therapy, and that's why it's not really used much. Another method for increasing HDL levels that we don't exactly do in clinical practice anymore because of these studies are the cholesterol ester transfer protein inhibitors. We're going to call it CETP inhibitors. So the primary mechanism of action for these drugs is to reduce the rate of transfer of the cholesterol esters from HDL into triglyceride-rich proteins. This leads to an increased content of HDL and larger HDL protein particles that are more slowly catabolized than normal. These inhibitors also decrease LDL through multiple mechanisms, but in terms of these trials, as you see, there's several trials investigating these ones. I wish I could pronounce these, but we'll call them the Illuminate trial, the Dow Outcomes trial, Accelerate, and Reveal trials. The first 3 trials actually failed in phase 3. The first one, torcetrapib, caused an excess of deaths and cardiovascular disease, leading to many to conclude that HDL was actually harmful. And then the second 2 drugs in the Dow Outcomes and the Accelerate trials showed that they were potent inhibitors, and of course they increase HDL. However, they just didn't see any benefit in cardiovascular disease, so they were stopped early. So that's why you see that they only lasted 31 months and 26 months. Lastly, the drug in the Reveal trial basically was the largest running trial for a CETP inhibitor, and it did show some possible effects in affecting coronary heart disease. However, the company, which was Merck and Company, sponsoring that trial, has not approved it for circulation because they didn't think that the power was enough and didn't have enough to back it. So we still do not use these to increase HDL and to decrease cardiovascular events. And then the third main group that I want to talk about in terms of increasing HDL is fibrates. We know that fibrates can significantly lower triglycerides. The number is about 40 to 50%. They modestly raise HDL-C by 10 to 25% and modestly lower LDL by 5 to 20%. But based on the randomized control trials-based evidence, fibrates the results seem to not be really consistent on if they reduce cardiovascular disease. The benefit really seems to be in a subset of individuals, and those subsets are patients with atherogenic dyslipidemia, which are patients with low HDL and high triglycerides. Also seems to maybe benefit the elderly, patients with type 2 diabetes, metabolic syndrome, and patients who are also on a combination of statins. All right. So these are just a few or the other non-pharmacological methods that we have been telling patients over the years to raise their HDL. Exercise, physical activity, smoking cessation, weight loss, and diet modifications. But it's worth noting that obviously these interventions don't just raise your HDL, they significantly impact your LDL. So that's likely why they do have significant risk modification on cardiovascular disease. So with all of these interventions that were designed to raise HDL, I wanted to know, like, what happens if your HDL is already high? And I was able to find a really good study called the CAN-HEART study that really investigated this. The CAN-HEART study is a study done in Ontario. It was done in 2008, and it was an observational cohort study that examined the association between fasting cholesterol measurements and all-cause, cause-specific mortality, I should say. The original population was 6.3 million that they included, but they got it down to 631,000 participants, which is huge. It's very huge. It's even bigger than the Framingham Heart Study total patients. So these patients were between ages of 40 to 105 years old without pre-existing cardiovascular condition. So this is kind of around the age that I am, and I don't have any cardiovascular disease, so I thought this was a good study to focus on. And of course, the primary outcome was cause-specific mortality, as well as looking at cardiovascular disease, cancer, and groups that don't fit into either of those. This was a 4-year follow-up study that ended in 2012. All right. So the participants were separated into several groups, which made it more easy to see, is high HDL beneficial? You have the less than 30 group, and then you have the rest of the groups that you see displayed on the screen. There is the reference group as well. As you see, men and women tend to have different levels of HDL. Women tend to have higher HDL due to estrogen. And there were some special considerations, which were their secondary outcomes. They explored the association between HDL and LDL. And the LDL parameters they looked at were less than 100 or greater than 100. They also explored what's the impact of statins in a subgroup of individuals that were older than 65 years old. And they also looked at the potential impact of obesity or BMI. But they only really looked at BMI greater than 25 or less than 25. All right. So these are some of the baseline characteristics of the study, and it is terribly shown, but I will detail what it says. So the mean age that they found from this study was about 57 years old. 55% were women, and the mean HDL-C level was 55. From this data, there's several things that came about. Increased HDL levels were seen with women and the elderly. Individuals with lower HDL-C levels had progressively higher rates of lower income, hypertension, diabetes, smoking, and COPD. LDL levels didn't really have a consistent relationship with HDL. However, triglyceride levels were lower in individuals with higher HDL. Another important finding was heavy alcohol consumption was more frequently observed among people with very high HDL levels. And the relation, yes. The study also included a survey of a little over 5,000 individuals, and it really showed a strong relationship between healthier lifestyle factors and increasing HDL. So individuals with increasing HDL levels had progressively higher prevalence of a lower BMI, moderate physical activity, and fruit and vegetable consumption. All right. So this is the graph that we're all interested in. So during a mean follow-up period of 4.9 years, 26%, so about 17,952 deaths, 26% were cardiovascular related, 38% were cancer related, and 36% were neither. So from what we see here, and don't forget that for men, the reference group was 41 to 50. And for females, the reference group was 51 to 60. But for men, the age standardized all-cause mortality rate was 8.1. From this data, people in the for men, so we're just on men right now, but people in the lowest HDL categories, I should say, so the less than 30 and the 31 to 40 category had significantly higher overall mortality rates. That's at 14 and 9.3, respectively. Also, people in the highest HDL stratum had a higher than average overall mortality rate. So that's for men. So you're seeing that greater than 90 category. Let's see. And we're comparing it to the reference group as well as the overall. So for women, the age standardized mortality rate was 6.6. A similar pattern was observed in individuals with lower HDL-C levels. They had a significantly higher age standardized all-cause mortality and all-cause specific mortality compared with the overall rate. Also, a higher than average rate was observed for non-cardiac, non-cancer mortality in patients, women with very high HDL-C levels greater than 90. So I know you're probably looking at this and you're looking at women and you're seeing the 81 to 90 category and the 1.6, and then you're looking at the reference and you're saying, oh, it's lower here for cardiovascular. Well, we need to take into consideration, this just shows the U-shape association, we need to take into consideration hazard ratios. Hazard ratio of greater than 1, so above that line here, above that one line, is going to indicate that the exposure being studied is associated with the higher risk of the event happening. If it's crossing 1, that shows us that there really isn't a good association. So from this, you can see that men with a low HDL-C, less than 30, still they had an increased cardiovascular mortality, as well as cancer mortality and other mortality. And you see that again with the high, greater than 90, had a significantly increased hazard ratio for non-cardiovascular death. And women, those with low HDL, still, as I mentioned, had increased cardiovascular mortality and cancer mortality. And lastly, women with HDL greater than 90 had an increased risk for non-cardiovascular death. All right. In terms of the subset analysis of the secondary outcomes, I mentioned that only some participants, took part in a survey. They were greater than 65 years old, and still this relationship, despite being on a statin, was observed that I just detailed in the other slides. Similarly with LDL, did not change the results, whether it was controlled or not controlled. And they used a BMI of 25, which isn't quite obese, but it's overweight, did not alter the results either. So the biggest limitations that I found from this study was race. Black Americans or non-Hispanic Black Americans actually suffer a disproportionate burden of cardiovascular disease at about 59%. African Americans having cardiovascular disease. In Ontario, the population is mostly English, European, patients of descent or people of descent of Italian, Irish, and Scottish ancestry. For perspective, in Ontario, the population for Blacks is about 5%. In the US, it's 15%. And in Georgia, it's 30%. And we know that there are certain diseases and factors that affect races differently. And so the fact that that information was missing, I'm not sure how, basically it's a limitation that I found. The other thing was the length of follow-up, which was 4 years or 4.9 years. We know that cardiovascular disease risk increases with age, and these patients were, as I mentioned, 40 to 105 with a mean of 55. And so it'd be nice to see, how patients do on a longer-term follow-up, something like the Framingham study. With alcohol and smoking status, a lot of data was missing for this. When I was just doing my research on this project, alcohol is actually a factor that can raise HDL. So it'd be interesting to see how many of those patients or people actually had heavy alcohol consumption. Even though that was included, they had a lot of missing data points. And then lastly, the most important thing is HDL functionality. So because all of these studies that I mentioned basically we're following concentrations of HDL, but it didn't have a strong association with cardiovascular disease, it's important to note that the functionality is more important and what studies have shifted towards. HDL functionality is dependent on the density of the HDL, the shape, and size as well. And that really is what is probably going to determine the atherogenesis of HDL. So in conclusion from that CAN-HEART study, we do know this from literature as well, that lower HDL-C levels are associated with cardiovascular disease. But from the study, we saw that it was associated with people that were more socioeconomically disadvantaged, with less healthy lifestyle behaviors, more cardiac risk factors, and a greater burden of medical comorbidities. As I showed you on that other slide, the relationship between HDL and the outcomes weren't linear. They were more so in that U shape where we saw patients with lower HDL had high risk, but also patients on the higher end had high risk in men, but higher risk for non-cardiovascular disease in women. So with all of this, it seems that HDL isn't an independent risk factor that we should be looking at. I think that we should stop telling patients that, just because your HDL-C is high, that it's great for cardio protection. We don't really know that from the studies. The only thing that's definite is that lower HDL levels, those levels that were less than 30, are associated with increased risk of cardiovascular disease. Any questions?
If you're viewing online and have a question, please enter it into the Q&A section and we'll ask for you. Any questions or comments in the room?
Thank you. That was really great. I was wondering if you had any thoughts between that relationship between high LDL, not necessarily great cardiovascular outcomes, and alcohol. Because it's, as you mentioned, people with very high LDLs might have higher levels of alcohol use. And I was wondering if you found anything in your research that might indicate a correlation there.
Yeah, actually, I did run across a study that did show that that was a factor. And in terms of, it's interesting because men, as you saw, had the ones who had higher HDL levels, so that greater than 90 category, had higher risk of cardiovascular disease. And it's proposed that it's because men drink more. So I think there could be an association there that we could explore more. But I did see that it was linked to higher HDL levels.
I would encourage you guys when you are sorry, I have a loud voice, so I don't need when you guys are in primary care clinic getting those lipid labs, and if you happen to notice a super high LDL, like 90 to 100 is kind of my cutoff, that might be a clue that a patient is drinking more than they initially tell you. So you might just want to hone in on that when you see that.
Hey, Amaka, great presentation. So I have one question. Is there any drugs that are affecting the HDL level? Because some anabolics, like steroids or somebody on like birth control pill and testosterone. I heard like beta blocker somehow and benzodiazepine. So did you come across something like that?
I did read something about beta blockers and steroids affecting HDL. The question then becomes, what can patients do if their HDL is high? And unfortunately, that data is scant. There are some genetic links to why HDL would be high, such as I mentioned the cholesterol ester transfer protein inhibitors. Well, some patients have a natural deficiency of that, and they will have naturally higher HDL. Whether or not that means they have a higher risk of cardiovascular disease, I didn't really go into that, and there haven't really been a lot of studies on what to do if you do have high HDL. We don't want to tell our patients to start smoking and stop exercising, but I think that that could be something that could be explored.
Excellent talk. Really enjoyed it. You mentioned earlier something about estrogen. I didn't hear all of it, but is there any type of relation to high HDL and menopause or perimenopausal women?
Ooh, that's a good question. I would not know that, but I would need to look that up.
Hey, that was a good talk. Really enjoyed it. I had never seen that Can-Hart study, so that was pretty cool. I had two questions. Number one is, how do you think you will start to talk to your patients about HDL and the relationship with their lipid panel? And number two is, where did you get that outfit?
Oh my God. Well, thanks, Vikas. That's a really good question. So I'm gonna back up on one of my slides here and show you guys what I started off with. So this is and my cohort knows this because this was a text message that I texted. I'll rewind since a lot of people weren't in here. But this is my lipid profile. I had some labs done, and my HDL was 82. So I appropriately texted my co-residents that I was gonna eat a bucket of chicken later, fried chicken, because I felt like I had good cardio protection. So I think what I will tell my patients who are saying like, man, my HDL is great, like, why do I need to be doing all of these things? I would tell them that, hey, there's not really an association between having these very high HDL levels and you being less at risk for cardiovascular disease, at least in women, right? So possibly for men, I'm sorry, still for both. But I would basically just tell them to still continue those non-pharmacological ways of basically taking care of their cardiovascular disease risk factors. So smoking, exercise, obesity, diabetes control. And I got the suit from Suit Shop online.
Very nice. Great job, Amaka.
Thank you, guys.